Welcome everyone. Thanks so much for joining us and giving 2.5 hours of your time. Really fortunate to be able to engage with all of you today. So my name is Patrick Chiu. I'm an assistant professor in the Faculty of Nursing at the University of Alberta and the lead of this project. Really great to see so many familiar faces on this Zoom call and also new faces from across the country. Before we get started, just some quick housekeeping items for accessibility purposes. For those of you who would like closed captioning, there is that option, and you can find that towards the right side of your Zoom screen on the bottom corner. Everyone is currently muted just because it is a fairly large group. We will enable the speakers to unmute themselves, and if you do have any Q&As, and if we do have time for Q&A, we will be sure to enable you to unmute as well. And lastly, we are recording the session and we will be posting it on the CHWN website, which is the Canadian Health Workforce Network. So before I begin, I just want to acknowledge that I am attending this meeting today on Treaty 6 territory, which is the traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence the vibrant community that I have the privilege to work, live, and play on. And I would encourage you to also share the traditional lands on which you're coming from in the chat. I am joined by a fantastic team of principal and co-investigators on this project. So Kate Leslie, Sophia Miles, and Hussein Ben Ahmed. You'll see their affiliations here on the slide. We're also all co-leads of different themes at the Canadian Health Workforce Network. And so for those of you who aren't familiar with the CHWN, we will just put the link in the chat. But it is a network that has been around for a decade now, really focused on mobilizing knowledge to inform decision-making. And it's led by Dr. Ivy Bergeau and a wide range of co-leads covering different themes and sectors. Also wanted to note we're joined by a fantastic group of research assistants, coordinators, and colleagues who will be supporting our breakout discussion. So really thankful for their participation as well. So just to give a bit of background, I think everyone on this call can appreciate that the healthcare landscape across Canada is changing very rapidly. That has required health profession regulators to make very bold changes to the regulatory philosophies, approaches, and processes. And so we're seeing a lot of discussion and focus on things like modernization, harmonization, work to strengthen regulatory approaches to respond to several system shocks, changes in the labor market, the integration of technology and innovations, as well as shifting public and government expectations. And we also know that many regulators and nursing regulators have implemented a wide range of changes to respond to these shifting landscapes. But in general, there's not a lot of strong and contemporary evidence that's available, specifically within the Canadian context, to support regulatory decision-making. And so we've recognized this gap for a while. We had put in a call or an application for a CHR planning and dissemination grant, and we were quite lucky to receive one. So the work that we're doing here today in terms of bringing everyone together is funded through CIHR. And our goal is to bring system partners like yourselves together in one room to really facilitate that collaboration, to co-create ideas for what are some research areas that we need to focus on, and also how do we maintain that knowledge mobilization and development as one regulatory system across the country. We know that the nursing system is unique, but the practice of regulation is also quite similar across professions. So just want to note that this work is sort of foundational. Our intent is to eventually broaden this to all health professions, but it did just make sense for us to start with nursing, given that it is the largest portion of the workforce. So here's our agenda. You'll see that the first half is focused on that knowledge mobilization piece. We have 4 speakers at the beginning who will help situate the discussion, really providing that research and policy context of nursing regulation from a national and global perspective. We'll do a quick break and then lead into 2 panels, one with our public caregiver and patient partners, and one with our regulatory colleagues. And then the last piece is really focused on seeking your perspectives and your ideas to our breakout sessions, and we'll allocate around 25 minutes for that. The plan here is to eventually develop a open access article to summarize some of the insights we'll glean from this discussion. But just to note that this is not research, does not require research ethics, and no one's responses will be linked to themselves. And so just wanted to make that clear at the outset. So we do have a pretty diverse group here. I'm looking at the participant list. There's 79 of us on the call and probably more joining. So if you do have your phone with you, I'd love for you to take a picture of this QR code. If you don't, that's okay. We'll put the link in the chat. And this is just to get a sense of who is in this virtual room. So I'll give you a moment just to do that. And also I'll stop sharing my screen and I'll bring up the poll just so that we can see where everyone is coming from. And so the link should be in the chat there. All right, so this first question, I see that people are already filling this out, is what is your primary role? I know many of us wear different hats, but think about your primary role. We got lots of regulatory professionals, leaders and staff, 71%. We have some researchers, government. I know we were supposed to have more government representatives, but I know in Ontario specifically, they're still under caretaking mode. So our colleagues there could not join us today. Got some educators, leaders of professional nursing associations, healthcare administrators, patient public representatives. And I do know we have point of care clinicians joining us as well. So it's great to see such a diverse group. All right, so if we just go on to, and I see some people still filling their responses in. Excellent. So this next one is just to get a sense of who is attending from a jurisdictional perspective. So if you want to fill out which jurisdiction you represent as part of your primary role. Right, so we see that there's pretty much every single province and territory that's represented here, which is fantastic. It's not every day that you get this level of participation, which is fantastic. And thanks so much for doing that. So lots from Ontario, Saskatchewan, Newfoundland, Alberta, BC, Quebec, Manitoba, New Brunswick, Nova Scotia, PEI, global as well. And then just to finish off this poll, one of the things that we're really doing is to discuss and collaborate on ideas to strengthen the nursing regulatory system. And I think in order to do this, we need to have a vision of what a high-performing system looks like. So in one or two words, when you think of this question, what does a high-performing nursing regulatory system look like? Jot down maybe one or two ideas that come to mind, and I'll encourage us to keep these in the back of our minds as we continue our conversation today. And so this will generate a word cloud for us. The more words that come up, the bigger it gets. So collaborative is something that is coming through real nice. Agile, responsive, timely, portable, equitable, modern, public safety, evidence-based. So it's shifting there. Collaborative, agile, safe, transparent, respectful partnerships, forward thinking. Excellent. And I'll just give it a few more seconds for those who are entering their responses. Great. Well, thanks so much for doing this. We will keep this image and share it with all of you. And with that, what I'm going to do is I'm going to turn it over to my research partner, Kate, who will start us off with the presentations, and she'll provide an overview of some of the work that she's done as part of the Canadian team leading the WHO's guidance for health practitioner regulation. So over to you, Kate, and thanks so much, everyone.
Wonderful. Thank you so much, Patrick. I'll just set up my screen sharing here. Wonderful. Hopefully you can see that there. Everybody's seeing me okay? Perfect. Wonderful. Okay, thank you so much, Patrick. I really appreciate being able to start us off here today. It's such a pleasure to be here. As Patrick said, my name is, you'll see me sometimes as Kathleen Leslie, but please call me Kate. I'm an associate professor in nursing, and along with Patrick, I'm the co-lead for the regulation and governance team of the Canadian Health Workforce Network. My area of research is always focused on regulation, so it is a real thrill to have this dialogue here today and to have so many wonderful system partners joining us. What I'm going to talk about today is some highlights from the WHO Global Guidance on Health Practitioner Regulation. So if you didn't know, the WHO released its first guidance on regulation in September of 2024. This guidance was based on a large-scale review of regulatory research, and I was part of the team that conducted that review. So we learned a lot about what the regulatory research shows and also where some of the gaps are. So that's my focus for today, to give us a grounding for our discussions about research priorities. So I'm speaking not on behalf of the WHO, but as a member of the research team that did the review for this guidance. The impetus for this guidance came about with the WHO recognizing the critical role of regulation in promoting some of the broader health system goals, alongside what we more traditionally think of with regulation of minimizing patient harm and ensuring a competent workforce. So it really is a very contemporary document. It's worth a read, and I have links to the actual guidance and some other documents that we'll be posting at the end. So this guidance was developed through a few steps. The first step was the WHO staffers did a preliminary scoping review just to understand what the literature base was on regulation. Then there was a technical expert group that was convened, and they set the parameters for the project. Then the WHO put out a request for proposals to conduct the large-scale global review of evidence. And I was part of the team with members from Australia and Hong Kong, two of us from Canada, Ivy Bourgeot and myself, that were on the successful team to get that bid. We started the review in 2021. It was complete and published in 2023. And then the guidance document was developed and worked its way through the WHO approval processes to be officially released last September. The review itself, I say large scale, and I really mean that. It was probably by a factor of 10 larger than any evidence synthesis that I've been a part of. We screened tens of thousands of articles and ended up including over 800 different sources. So what did we find, and what were some of the gaps? First, on regulatory design, there were so many different approaches to regulation. We talk about regulation being different across Canadian jurisdictions, but when we look globally, there are so many more variations and different approaches to regulatory design. We did see some evidence towards moves to what we termed as risk-based regulation or risk-based models. We might also call right touch regulation in some places. And this includes trying to identify higher risk occupations that should be regulated, and then within regulated groups, identifying higher risk areas of practice and higher risk registrants. So there are a few, risk-based models that we can identify, but there are very few comparisons of different regulatory models. So we don't really know what works best in what situation. Second, when we looked at the outcomes of regulation, there just wasn't a lot of research that linked regulatory interventions with patient outcomes, with public safety and population health. And the research that we did find around that didn't take an intersectional or gender-based lens, so we felt that that was missing. Third, on regulatory innovations, we did find some evidence around regulatory reforms and innovations. These were primarily driven by jurisdiction-specific needs, and they were influenced by the perspectives about public interest. And the guidance has a great chart about contemporary views of the public interest versus more traditional views of the public interest. An example of more contemporary views being recognizing that adequate health human resources is in the public interest, and diversity of providers is in the public interest, and regulatory reforms that recognize that. There were, of course, also many innovations during the pandemic, and these provide us with some opportunities to try to identify what works best, and what are some leading practices, both for steady state and also for the next crisis whenever it hits. And the final finding that I'm going to mention is, and there was a lot of space in the WHO guidance dedicated to this, the regulatory practice gap. This was basically described in our meetings with the WHO as a difference between regulation on the books and regulation on the ground. So when you have good policies that are not implemented, or good policies are implemented, but they fall short of their objectives. And why is that? And the guidance document talks about some of the key drivers here, not taking context into account, a focus on activities and outputs rather than outcomes and impact, and capacity constraints, very real human and financial capacity constraints that we face. So, practically speaking, thinking about the state of evidence for regulation right now, what are some areas that we can focus on to drive regulation forward? And I know our next speakers will also have some ideas on this as well. But from the WHO report, here are a few of the global highlights. And I also want to note here that I think sometimes we have the tendency to consider, that nursing is so unique. And of course, nursing is very unique and wonderful. But in terms of regulation, we can learn a lot, not just by working with other nursing regulators, but by working and looking to other regulated health providers, and also just looking at other regulated industries outside of health. We can also learn a lot by looking at countries outside of what I would call the usual suspects that we do comparative work with, Australia, the UK, the US. Lower and middle income countries have done a lot of excellent regulatory strengthening work. And sometimes, unless that work is sponsored, you're not going to find it in a peer-reviewed publication. So the work is being done, and if we know where to look for it, we can learn from it. So on that basis, can we create a way to track some of our regulatory research? And second, can we do this using more standardized measures and common frameworks? This would make our comparative work a lot easier. And part of that work can start today. Our team has a goal of having a regulatory research and knowledge mobilization hub in Canada that partners with other people and groups doing similar work across the globe. My third point here, can we start thinking about designing projects that focus on outcomes and impacts of regulation to inform our regulatory design? Fourth, can we ensure that we're using gender and intersectional lenses in our research? I know in our own research projects, we take a sex and gender lens, but we're always learning how to do this better. And finally, a recurring theme I think you'll hear more than once today is that working together as partners, we can really help drive the evidence base and advance regulatory science. So I do have a page here that we'll post in the chat. You can also scan this QR code if you like, that'll link to some of the documents I've talked about and provide some additional resources. Starting on the left here, this is our academic paper from the integrative review. Second, we wrote a large report that's posted on the Canadian Health Workforce Network website. The third image here, that's the title page from the actual WHO guidance, so I've linked to that as well. And finally here, there's a YouTube video that you can find on the CHWN YouTube channel. It's a panel that we presented with WHO at the International Health Workforce Collaborative. It was just over a year ago now, December 2023. And some big names in regulation, Andre Gariepy, Harry Caton, make some cameos at the end, so it's worth a watch just for that. So I'll end off here, kind of ending back where I started, which is that I'm really, really thrilled to have this dialogue come together today and see so many of us come together to talk about this. It's a big step, and we can keep moving forward together. Thank you so much. I'll pass it back over to Patrick.
Excellent. Thank you so much, Kate, for that wonderful presentation. And for those of you who weren't familiar with the WHO guidance, I really encourage you to look at it. It is a fantastic resource. So next up, I would like to bring forward our colleague, Lisa Little, who many of you will know, Canadian nurse, but also has a very large global presence. Currently first vice president with the International Council of Nurses. And Lisa will provide some of the policy context as it relates to nursing regulation from a global perspective. So we'll let Lisa, you share your screen, and over to you. Thanks so much.
Thanks very much, Patrick. Very kind for the invitation. I'm just going to share my screen. And just let me know in a second if you can see that.
Fantastic. Yes.
Okay, great. Thanks. Okay, so wonderful to be here today. I do want to acknowledge that I'm on the unceded traditional territory of the Anishinaabe Algonquin Nation. And I do reside in Canada. Obviously, as Patrick mentioned, I'm the Canadian and North American and Caribbean representative to the ICN Board of Directors and the first vice president. For some of you, just an introductory slide about ICN, you may not know. We are a federation of more than 130 what we call our national nurses associations. And of those associations, we have a mix of regulators, professional associations, unions, and any combination thereof. So in some countries, the regulatory body is also the professional association. In some cases, it's also serves as a union. So there's lots of combinations around the world of what we see in terms of nursing regulators. We represent 28 million nurses around the world. We are the first non-NGO organization to be recognized by the World Health Organization. And of course, we represent the largest number of healthcare workers globally. This is just a snapshot of the board if you're not familiar with our ICN president, who's Pam Cipriano, and many of you may also know our CEO, Howard Catton. So Patrick asked me to present on global trends and issues and to do that in 10 minutes, and that's quite a feat, to be honest, but I just tried to do some slides with some points, and I'll speak to them. So I want to begin by prefacing that saying, you know, Canada has very strong nursing regulation, and it's recognized globally for that. I'm not saying we're perfect, and I think there's still variations within our provinces and territories, and maybe where, as you said, we'll learn today where there's some improvement that's possible. But what I want to provide today is more of the global trends and issues. And so to begin with, we see at ICN variation in the strength of the nursing regulation and the regulators who are our members. For example, Korea just got their first Korean Nursing Act in 2024. Previously to this in Korea, they were under a Medical Service Act where nurses were classified as subordinate to physicians, which limited their work to that of assistants rather than the autonomous professional. So there's still a wide range of nursing regulation and where it's at across the globe. And in terms of the regulators themselves, there's also variation in strength in their capacity. ICN is doing some work in Africa under what we call the ODENA project, the Organizational Development of National Nurses Associations. We have 23 African nations represented there around the table. And that's really about capacity building for those. And we've learned that many of them as well, you know, are at various stages of the strength of their regulation and the various components of regulation. And one of the big pieces we do with that is actually a twinning piece. So we pair them with regulatory bodies and professional associations who are stronger in other countries who wish to support them, to provide some of that coaching, to share their resources, etc. So really a collaborative piece and partnership is at the foundation of that. So again, that piece is very prominent. There's also variation in the role of the regulatory bodies in nursing, I'm speaking, in setting pre-registration education standards. So some of them do that, some of them do not. Some of them in countries, it is approved by governments, not by the regulatory bodies. And the context of those standards also change in terms of the balance between theory and classroom and simulated learning and how many hours of each or what's required. Also, interprofessional education standards is a piece that is not yet pervasive across our nursing regulatory bodies. If you look to the State of the World's Nursing Report, only 2/3 of the members reported having standards for interprofessional education. We also still see that nursing education around the world, we don't have international standards. So in Africa and Western Pacific regions, it's 2 to 3 years for about 75% of those countries. And in the American, Southeast Asia, and Eastern Mediterranean regions, it's 4 or 5 traditional years, as we know here, as sort of the standard baccalaureate entry to practice. There are challenges to self-regulation. I won't negate that. In some countries, the nursing regulatory bodies are actually part of government, so they're not independent organizations. There are challenges to the self-regulation, that many of them are still being challenged to be taken over by other organizations, by governments, etc. And so that's always a challenge and a risk that's been there. When we talk about annual registration, I mean, again, Canada is very strong in that we have annual registration and requirements that you must meet within the PT regulatory bodies, but that's not the case around the globe for everyone. We have some nursing regulatory bodies in, for example, in Southeast Asia, where they license once and they never license again. So we have no idea where they are, where they work, what they're doing, if they're still competent, etc. So that's a huge challenge for some. Various stages of NP and RN prescribing legislation and regulations. Of course, we're fairly advanced here in Canada, but there are many countries that don't have that. That was evident in the State of the World's Nursing Report as well, about, I think it's around 50% of the world of the nursing regulatory bodies in countries have NP legislation and regulation to move forward. So a gap as well. Let me just quick slide here. So the next one is about the mechanisms to support mobility of nurses in emergencies and disasters. Certainly COVID-19 and the various emergencies and disasters of all kinds, not just COVID-19, that we've seen and are currently experiencing in the world, have pointed to the need for enhanced regulatory mechanisms to support countries and regions in terms of timely mobility of nurses. I think Canada has done very well in this area, but there are still circumstances and regulations in nursing regulatory bodies or bylaws at whatever level they are, that don't allow that quick mobility to send nurses into other countries, to get them licensed quickly, to be able to be boots on the ground to support in those emergencies. Social media is one that's come up a lot. There are varying policies related to the use of social media by nursing. Many nursing regulatory bodies have put out guidelines on the appropriate use of social media, but many have not. So again, an emerging issue about what can nurses say in social media that is appropriate according to the standards of practice. This is one of the ones that was mentioned earlier already. We lack common data sets captured by regulatory bodies across the globe to do meaningful comparisons. So even within our own country, we don't all collect the exactly same information by the nursing regulatory bodies. There is a standard, a minimum standard, but then everyone has their own thing that they collect on top of that, and take that to a global level, and it's even worse. The National Health Workforce Accounts at the WHO, which was the basis for the State of the World's Nursing Report in 2020, enabled us to put all that data in. It was cleaned by WHO, but it's very basic information. There's not a lot of granularity on hours worked and whether people are working in the public or the private and what are their sick time and those kinds of things. ICN would certainly like to see more here that we can start to compare internationally. The next bullet on here is really what's been brought up as well, is about collaboration. What we've seen is that there are what they call the quads. So regulators working with professional associations, unions, governments, and employers on a lot of the decisions that are made, whether they're changing regulations, bylaws, guidance documents. And we first saw this actually happen in Africa. So they have what they call the Quads Collaborative, and that's a formal table where all of those come together in those countries to discuss nursing regulation and changes to nursing regulation, changes to nursing education, etc. So a really effective form of collaboration in that model. One of the biggest things that's happening that ICN's very much been in tune with and has spoken about publicly, as you would have heard, is that we know from our members in conversations where we've been in Africa, for example, and we've been in other countries, and they tell us the numbers of the nurses they're losing who are moving to other countries. So the issue of mobility and migration. But there's a lack of good data on it. So who captures this? Is it immigration departments? Is it nursing regulators? Is it WHO? Is it the ILO? And is it ethical as defined by the WHO, which has been, the code of ethical practice, which has been signed on by all governments, including Canada. We know, for example, there's still a lot of unethical migration reported to us by our members. And what is the appropriate role of nursing regulators in international recruitment, in making sure that things are done in an ethical way? So there's a lot of questions around that, and trying to get to the email. The code of ethics. So most regulatory frameworks have a code of ethics for nursing. ICN has a code of ethics, which is updated every 5 years, I guess. It's used by many national nursing associations. And I would say probably more those that are middle to low income countries who perhaps don't have the resources or capacity to develop their own code of ethics. But I think there's an opportunity to collaborate better across the globe on this. Why do we need 20 or 30 codes of ethics for nurses around the world? ICN does a collaborative call out to its national nursing associations, which of course includes Canada, who's our member. The Canadian Nurses Association is the member of ICN. And so I still think there's room for that in terms of being forward thinking and developing things that we can all share. The virtual work of nurses certainly accelerated tremendously after and during COVID. And there's complexities around that in terms of the regulation of nurses who work remotely. Even in our own country, it varies by jurisdiction about what the requirements are, where you have to be licensed to do remote work. And that also moves to the global perspective as well. And many of them have not even brought this into their regulations about virtual work and where you need to be licensed. Many nurses are working across borders these days. The last one on this page is about baccalaureate entry to practice. In light of the global nursing shortage, we're seeing more noise, I'd say, about the baccalaureate entry to practice. Some countries and nursing regulatory bodies do not have baccalaureate as entry to practice still, as we know. And others are getting pushback who do have it from their governments, saying, well, if you could just reduce that by a year or two, then we'd solve the nursing shortage. We'd put out more people in a faster time. So that is not off the table, even though we probably thought it was for many years, and we thought we'd achieve things. It's back on the table again. Title protection. In some countries, there is a lack of title protection for nurses. So I know in Canada, we're pretty consistent in who can call themselves a nurse. And we have that in our legs or regs or bylaws, whichever level it is in the jurisdiction. But for example, when ICN asks its regulatory members how many nurses it has registered, the response can be ambiguous and unclear. There are different education requirements and, as I said, no title protection. And so we find that when we ask them, and some of them also register as what we would call these sort of traditional unregulated healthcare workers. So patient care assistants, nurses' aides, they're also licensing them. And so when they say, well, we have this many nurses because they're called a nurse aide, we have to dig very deep to find out what is the education, what are the competencies. It's not clear. And some nursing regulatory bodies are, as I said, registering or licensing what we would call those unregulated workers. And some ask if that is the role of nursing regulatory bodies. Is that going to lead to confusion? Is that going to lead to an effective model for nursing regulation? The move to just culture, the patient safety agenda. I know we've talked about right touch regulation already. This is an approach that's coming forward in schools of nursing, in employment settings, and nursing regulation, where it's really about a learning approach that aligns with the patient safety culture of we want people to report errors or near misses and be confident that they can speak regarding their own actions without punitive measures being taken against them all the time. So that's about finding a balance. And I think that's important that, that's a piece that is going to continue to evolve, I think. Over time, we've seen a shift where legislation and regulations and bylaws used to be very restrictive, I'd say, with lists about what nurses could do and couldn't do. And there's been that shift to more broad, general and less restrictive, more flexible wording that allows nurses to work to their full scope of practice. But I'd still say that the scope of practice is a difficult one for people to understand, and I don't think there's full clarity by everyone. I think that there's the regulatory scope of practice, there's the employer scope of practice, and there's the individual scope of practice. And with the language becoming so broad and open, there's becoming a lack of clarity between what is the difference between a registered nurse and, let's say in our country, the language of a registered practical nurse or a licensed practical nurse. And so it comes back to then what are you taught in school as opposed to, and then what are you confident to do? So it is becoming more ambiguous for people, I think. And so there maybe needs to be a bit of a balance there as well about what that looks like. But we certainly support nurses being able to work to their full scope of practice and education. The last one on this page is about continuing competence requirements, just to say that that varies across the country. Some regulation of nursing has no continuing competence requirements in many countries. And what does that look like? Some of them, it's the hours of practice that you have, or you have to have, continuing education credits. Other ones, it's more of a self-reflective model. It varies greatly. And the last slide, I'm just going to go to, let me just move my thing. And this one maybe is a bit contentious, but it's really about the balance between public protection and supporting the profession by regulatory bodies is often questioned. So issues of poor staffing levels or poor working conditions, whistleblowing and other things, nurses' safety are often sort of avoided, if you will, or dodged by regulators in our experience globally. But yet we know from years of research that poor staffing levels lead to poor patient outcomes, which is patient safety, which is public protection. We know that nurses working overtime leads to patient errors. So it all depends how you interpret it about what is public safety and public protection and how that impacts nurses, about what is the full role of nursing regulatory bodies, right? If the shortage and workforce imbalances are now seen as part of the public interest, then surely patient safety issues and the working conditions upon which nurses practice could be seen in the same light. So this is an ongoing dialogue and discussion that we've heard happen globally around the world. And that is the end of my slide. So I'm hoping I kept it 10 minutes. I just want to thank you. And note that the next State of the World's Nursing Report will be out just very shortly in April or May. And so that may shed more light on global differences in nursing regulation, because there are questions in there about what aspects and components of nursing regulation exist in the various countries around the world. Thank you.
Excellent. Thank you so much, Lisa, for those fantastic points, and really highlighted the importance of attending to that global context as we continue to live in this increasingly globalized world. What's happening in the global space definitely impacts us here at home and vice versa. So thanks so much for all your leadership at the ICN. So I'd love to sort of bring it down to the national level and invite our CNO, federal CNO, Leigh Chapman, to join us and provide some remarks. So Leigh, over to you to provide some context in terms of your priorities and what you think we need to focus on from a nursing regulation perspective here in Canada.
Okay, perfect. Thank you very much. Bonjour tout le monde. I'm delighted to be here, and really thank you, Patrick and colleagues, for putting this on today. It's such an important topic, and I'm just so thrilled. There's so many folks who are as interested in this topic as I am, and who are joining today. So I don't have slides. I'm just going to speak for a few minutes, probably not the full 10 minutes, but really happy to give you a bit of Canadian context in terms of what the priorities are. And I would say the priorities are really the same as since I started in the role 2.5 years ago around increasing the integration of internationally educated nurses. I think the language specifically was around accelerating the integration, but I'm going to tease apart the notion of acceleration, increasing mobility, and improving our workforce planning data. And those are still priorities. I know Kai is doing some work on a minimum data standard. All of you will be very interested in the Unique Identifier Project in Canada. If you don't know about it already, the Nurses NURSYS in Canada project, which is very exciting, hopefully for everyone attending today, around having a unique identifier for nurses and better integrity of the data. And I would say, when it comes to internationally educated nurses, we've seen this be one of the, I would say, one of the fastest moving areas of policy. And this is where we've seen the notion of acceleration not always be such a benefit or a gift. We've seen massive shifts from a policy perspective in regulation, and in some cases, it's actually resulted in internationally educated nurses who are licensed and registered but unemployed and unemployable. And the service side of healthcare then has to figure out a way to integrate them into the system. The post-secondary institutions have to figure out how to develop programs to meet their needs for those who may be licensed and arguably in good standing, but may not have the recency of practice experience. And so this is the tension, I think, that exists in nursing regulation in Canada. We need evidence-based regulation. We need right touch regulation, compassionate regulation, all those words that you certainly heard, but we also need nimble and responsive regulation, which sometimes is in tension with notions of safety. And we know there also have been incidents of fraud. There are, title protection is still a challenge when it comes to imposters. We know there are safety concerns when it comes to conduct and so on. And so balancing the tension is the inherent challenge, I think, that nursing regulators face today. I know there's many on the line, and they have moved mountains since over the last few years, certainly. And with the COVID-19 pandemic, I think the work of regulation has become increasingly important. And it will remain so when it comes to our health workforce challenges. When we think of the impact of AI and technology, Gen AI, climate emergencies is actually kind of breaking down our jurisdictional boundaries when it comes to evacuations, fires, floods, all the things that many nurses are actually having to contend with, and really don't have competencies to manage evacuations. This is something that really hasn't been covered when they're evacuating entire health facilities. Future pandemics, Kate alluded to this as well as shifting models of care. We just released in January an interpretation letter on the Canada Health Act, which I hope will be historic in terms of how nurse practitioners and other providers may be integrated into our health systems across the country. And then the primary care conundrum in Canada, the millions of people in Canada who don't have access to primary care. We've seen this in the headlines, people lining up for primary care providers, and how this creates an access challenge. And so I think the challenge or the challenge du jour is really in looking at how regulation interacts with the rest of the system. Whether, when we're licensing folks, are they employed and are they employable? Are they able to meet the practice standards, or is the health workforce crisis such that nurses are not able to practice according to the standards? And all of these interconnected parts are so key in our health workforce challenges that we're facing. And I will just say that, the issue of mobility remains a challenge, not just for internationally educated nurses, but for all nurses. I think that Lisa has alluded to this as well in terms of our global nursing workforce. That's certainly why I've been focusing on retention, because we know we have a shortage of nurses internationally, but we also know that we have incredible mobility of our nursing workforce across the country. And so it's not that we will be able to recruit our way out of this, but we need to think more in terms of how we can leverage mobility as a means of moving nurses to where they want to work and where they're able to work, and breaking down some of those barriers that may exist to practice. The First Minister's issued a statement yesterday, which I can post in the chat, really highlighting the need to advance mobility as well, given the geopolitical challenges that we're seeing in North America. So I really want to acknowledge the incredible work that regulators have done in Canada, cheer them on in the work ahead, because I know the work continues and there's lots of work that needs to be done. And I think exploring this from a research perspective is vitally important, because regulation has such a key role to play when it comes to our health workforce challenges. So thank you very much. And merci beaucoup, and I look forward to the discussion.
Thank you so much, Leigh, for those remarks, and definitely no shortage of work for us to do when it comes to strengthening the system. But I think what we've been hearing from all of the speakers is really the importance of looking at regulation from a systems perspective and recognizing that we don't exist in a vacuum. So that was fantastic. And what I'm going to do is now turn it over to our colleague, Natalie Thiessen, who is our research associate with us. And she's been working on a few research projects. And specifically today, she'll talk about the research context and drawing on a scope review that we have completed, currently in peer review, looking at nursing regulation evidence in Canada. So over to you, Natalie.
Okay, you can hear me saying,
yes.
Oh, okay. All right, so just get myself prepared here. My name is Natalie Thiessen. I'm a research associate, as Patrick said, with Athabasca University, and I've had the pleasure of participating in the scoping review exploring the literature on nursing regulation in Canada, and I'm looking forward to sharing the insights from this review with you today. So our presenters today have really set the stage well by providing key insights into the complexities of the nursing regulatory environment in Canada and the pressures that nurse regulators are responsive to within this context. And this serves as the background of this review. So while previous reviews, like the one that Kate described earlier, have explored health practitioner regulation in national, international, and interprofessional contexts, there's none that actually are specific to Canadian nursing regulation. So we set out to fill this gap by assessing the nature, extent, and range of the literature specifically informing the regulation of nurses within the Canadian context. We also wanted to assess how the existing literature aligns with emerging health profession regulation trends and identify any knowledge gaps that may exist. So we conducted a scoping review following the rigorous Joanna Briggs Institute methodology, as it was the most effective to address broad research questions like these and summarize the literature in this emerging field of research. Our systematic search identified 195 relevant sources published before March 15, 2024. We included all source types, including non-empirical and gray literature, if they provided substantive focus on the regulation of any or all nursing designations in Canada. We extracted relevant data from each of the sources and categorized them in various ways to gain an in-depth understanding of the nature, extent, and range of the literature base. So, of the 195 sources included in the review, 80% were scholarly literature, although half of these were, or roughly half, were non-empirical sources such as discussion papers, commentaries, editorials, etc. Of the 81 empirical sources that we found, 45 used qualitative methods, 17 employed mixed methods, and only 7 were quantitative. The remaining 20% of the literature base consisted of gray literature, including sources like theses and dissertations, regulatory reviews and audits, commissioned research study reports. All of these were published outside of your traditional publishing channels. An analysis of the year of publication reveals a significant increase in the number of publications related to Canadian nursing regulations since 1995, with a current average of approximately 12 publications per year. A total of 104 sources focused on nursing regulation in only a single jurisdiction, with Ontario, British Columbia, and Alberta being the most well represented. 67 sources took a pan-Canadian approach, and 24 compared Canadian nursing regulation globally. Regarding authorship, 33% of the sources were produced, written, or commissioned by individuals affiliated with a regulatory body. We also categorize the sources based on their focus on structures, processes, and outcomes, using a framework from a larger scale review of regulatory literature. So roughly 35% of sources focused on structures or the contextual factors impacting regulation. The majority, so 60%, examined regulatory processes or the activities of regulatory bodies, and only 5% evaluated outcomes, such as the impact and effectiveness of regulatory systems and functions. So additionally, we grouped the sources into 6 core regulatory functions. The most well-represented category was the regulatory models, governance structures, and reforms, which accounted for 30% of the total sources. Registration and licensure, as well as nursing roles and standards, were also well represented comparatively, making up 29% and 27% of the literature base, respectively. The regulatory functions function of conduct, complaints, and discipline was less well represented at 6.7%, followed by continuing competence programs at 5.7%, and education program approval or accreditation appeared as a focus in only 1% of the literature. So the scoping review highlights that Canadian nursing regulation is an emerging field of research with significant opportunities for further knowledge development. Regulatory bodies have been actively engaged in the creation of the existing literature base, which paves the way for opportunities for increased collaboration and continued collaboration between researchers and regulatory leaders on research goals and knowledge mobilization strategies, which is bringing us here together today. The literature base reflects the current regulatory landscape, with all core regulatory functions represented at least to some degree. However, our review also identified there's a notable imbalance in the research methodologies, with quantitative and mixed method studies being underrepresented. There is significant lack of outcomes-focused research, something we've heard already today, and limited evidence supporting the effectiveness of core regulatory functions. So as a result, the literature base actually falls short of adequately supporting evidence-informed regulatory decision-making. So while a few of the core regulatory functions are comparatively well represented, there are gaps in the literature related to conduct and complaints, continuing competence, and education program approval or accreditation functions. And additionally, we found a gap in the literature addressing critical issues within the regulatory environment, such as racism, equity, and the integration of technology. Finally, despite ongoing trends in Canada towards adopting umbrella legislative frameworks that govern multiple professions and the amalgamation of professional regulatory organizations, only one single source compared the regulation of different nursing designations, and another single source compared nursing regulation with other regulated professions. So this indicates that nursing regulation scholarship in Canada remains isolated from the broader professional regulatory landscape. So where do we go from here? Moving forward, there are significant opportunities to strengthen the literature supporting nursing regulation in Canada. Future research should focus on addressing key gaps in the literature by prioritizing the evaluation of regulatory outcomes and impact of the various core regulatory functions using diverse research methodologies, including quantitative and mixed methods approaches. Research should attend to key issues in the regulatory environment, including the outcomes related to reform specific to DEI and anti-racism and integration of technology, among others. And Canada's federated model is noted in the literature as a key challenge. Regulators are already working to overcome this challenge by engaging in various pan-Canadian collaboratives, such as the Canadian Nurse Regulators Collaborative, or CNRC. These established collaborative hubs can continue to support pan-Canadian regulatory discussions and potentially serve as a venue for collaboration regarding research initiatives and knowledge mobilization. Nursing regulation does not exist in isolation. There is an opportunity for more interprofessional and interjurisdictional research to strengthen the evidence base for professional regulation generally within both the national and global healthcare contexts. And finally, collaboration between regulators and researchers can be strengthened through co-creating a research agenda and developing more effective knowledge mobilization strategies. And this is precisely the goal of today's dialogue. And we are very much looking forward to hearing about your ideas during the breakout sessions later on. That concludes my presentation. Thank you so much.
Excellent. Thank you so much, Natalie, for that. And we'll be sure to share the publication once it does go through that peer review process and gets published. So we actually do have a few minutes for questions and answers. I was actually afraid that we would go over time, but everyone stuck to their 10 to 15 minutes, which is fantastic. So if you do have any questions or comments for our speaker, feel free to add them to the chat. And we'll see what comes through. And while we're waiting for that, maybe I can get us started. I know we've talked about so many different research topics, policy priorities. As I mentioned, there's lots for us to do to strengthen nursing and health professions regulation. But I would pose a question to the presenters. If you were to maybe pick one or two priorities that you think can have the biggest impact to improve nursing regulation or health workforce or public safety in general, what's something that comes to mind? And I'll just open it up if you're comfortable with answering that.
I can go first, happy to. Thanks for the question, Patrick. I think my two would be the move to evidence-based regulation. I think we make a lot of decisions in the best interest and trying to do a good job, but we don't really understand the sequelae of some of those sometimes and the repercussions of those. And so looking at an outcomes perspective from the research, I think is really important on the changes that we make in regulation. And I think the collaboration, and I think that collaboration goes in many different ways. I think it's within a country, I think it's globally with partners, but I think it's also outside of nursing regulation. As I said, the Quad model in Africa, where they bring in employers and educators and professional associations so that decisions can be made with full perspectives to understand what the implications might be or the pitfalls that they might be, and that everyone can be prepared and be reacting to, in a proactive way. I think is really important that we said nursing regulation doesn't happen in isolation. It happens in a broader context of a lot of other, and you said it yourself, we need a systems approach. Yeah, and in a formal tables, not just a ad hoc consultation here and there, I think. And I think that happens across the globe where we could be sharing as well with regulators. They made a change before us. What happened 2 years after they made that change? What were some of the outcomes that perhaps they didn't anticipate?
Okay, thanks, Lisa. Leigh, Natalie, Kate, any thoughts on your end?
Yeah, I'll hop in here quickly. I will add that I absolutely agree with Lisa's points too. I'll also add the priority around the data piece. I think the data that we have at regulators is really, really rich, but I think there's a untapped potential for research and understanding within that data, sharing that data, understanding how we can best do that and use it appropriately for both advancing regulatory policies and processes, but also understanding the link to health human resources in Canada and globally, and just better leveraging the wonderfully rich data that we have and ensuring that it can speak to itself and speak to others and has interoperability in that way, and also has some potential for analytics.
Great, thank you, Kate. Anything to build off on that, Natalie, Leigh? If not, we'll move on to the next.
I think the challenge is that there's just so much that we need to know still. There's so many opportunities. So I wonder if like a very practical, pragmatic place to start is looking at outcomes of the reforms that we've already been putting in place. So I know that Dr. Chapman brought up the IEN reforms and just the tidal wave of changes that have happened in that field. And so starting somewhere like that, and I know our team is doing some of that research, but I think that starting with some of the things that are already implemented really offers an opportunity for some of those outcome evaluations. But
Thanks, Natalie.
And yeah, I mean, I would agree with everything that has been said, and just add that, thinking about how we balance jurisdictional autonomy in a federated nation like Canada with a more seamless process for the end user, really the applicant, the registrant across Canada. Nurses, I think, will be an enabler and will help with that, but also thinking about it almost from a customer service perspective, how do we balance safety with a more seamless process across the country that's more uniform? Because we're already seeing things like jurisdiction shopping happening because of disparities in requirements, or not disparities, just differences in requirements across the country. And so how can we think of a made in Canada approach that is more seamless?
Great, thanks, Leigh. So we have 5 more minutes, and I'll select one more. I know, Anja, your question was already answered by Lisa. Sally, Dr. Sally Thorne, we can always count on Sally to ask some thought-provoking questions here. So the question that Sally posed here is, do we fully understand whose interests are being served by various trends in regulatory practice? And are there contested interests that need to be brought to wider attention? What is everyone's thoughts about that question? I see some thumbs up and likes to that comment.
I mean, I love Sally's question, and she obviously words it way more eloquently than I could. But the contested interest is this notion of tension that I think we need to acknowledge and recognize, and think about. There's political interest, of course, in this topic. In regulation writ large. There's the nurse themselves. There's the service side of healthcare as well that, wants as many nurses as you can register and license as quickly as possible but we also need to balance safety. And so I think there's many different players, and just trying to find the alignment between all of those different interests, and acknowledging the inherent sources of tension.
Great, thanks so much, Leigh. And Valerie, I know I saw your hand up, so feel free to ask your question, or you've put it in the chat, so maybe I'll pose that. So Valerie from CNA, her question was for another time, it may be embedded in the comments, but back to the outcomes focus, what is nurse regulators' roles in demonstrating the outcomes to support workforce optimization? For example, RN prescribing and minimal conduct and negative outcomes. So the question is, what are nurse regulators' roles in demonstrating the outcomes to support workforce optimization?
I can quickly try to address that, but I think, Valerie, you're right. That's a great question for us to continue to ponder and maybe get into in our breakout rooms as well. But certainly, I think that there's a continued trend that we've seen of increased accountability and potentially, government oversight or different sort of ways for regulators to being expected to demonstrate their effectiveness and their efficiency in meeting their mandate of the public interest. And I think part of showing that is being able to demonstrate impact and outcomes, rather than just focusing on the inputs. So I think that workforce, in terms of specifically around workforce optimization, that's a little bit where that tension comes in terms of, historically, regulators not wanting to be seen at all as advancing professional interests if that was opposed to public interest. Although now, of course, there's a much more nuanced view of that, and I think that that's again a continued conversation that's shifting and changing. But I think around understanding what the outcomes of some of these reforms are, as Natalie was saying, if we've got a reform in place, I think a good way to start is to look at what are those outcomes, and one way is around are we supporting workforce optimization? Does that impact then on patient outcomes, public health, population, access to health, access to care?
Great, thanks so much, Kate. So I think that brings us to the end of our 4 presentations. What we're going to do now is just take a quick 10-minute break. So for those of you who are Eastern time, that is going to be 1:15. For us here, Western and Mountain time, that's going to be 11:15. And once we come back, we are going to lead into our 2 panels, hear from different perspectives, including our public patient and caregiver partners, as well as our regulatory colleagues in terms of some of the important work that they're doing. So we'll take a 10-minute break, and then we'll come back and get into the breakouts and panel discussions. Thanks so much. All right. So as we wait for everyone to come back, we'll just pull up our public patient and caregiver partners who have graciously volunteered their time to join us today. And we're going to do a bit of a rapid fire chat. It's 20 minutes each, so it's not a lot of time, but just enough for us to start the conversation, and just to note that this is really one of many conversations that we'll be having, and that we'll be bringing system partners together. And so I'm very happy to be joined by our public patient and caregiver partners, Alison, Anja, Lanz, and Chen. And all 3 of them have some level of experience engaging with regulators, either as regulated professionals themselves in different professions, or individuals bringing the public patient and caregiver perspective in regulatory work. And we really wanted to include this piece in our dialogue today, because despite regulation being focused on regulation, or public protection rather, we actually really rarely hear the public voice in these discussions, and we found that in our scope review as well when we looked into the literature. So really, thank you, Alison, Anja, and Lynn, for taking the time to join us for this conversation. So the first question I just wanted to pose to all of you is from a public and patient/caregiver perspective, and having been involved in regulatory work, from your perspective, what are some areas that you think can be strengthened to ultimately enhance patient and public safety? And perhaps, Alison, I'll go to you first.
Thank you, Patrick. Good morning and good afternoon to our Eastern and Central Canadian partners. I think one of the first things to me would be legislation of nurse-patient ratios in all provinces and territories, which would, I believe, create a safer and a safer situation and care for the public, for patients. Number 2, not all health care regulators in British Columbia anyway, and I've worked for 3, use public members in the same way. Harmonizing the practice of allowing public members improves the lens from the public, but it also creates safer practice as we become more skilled in these areas of work, like doing the work we're doing today, and where the 3 of us are part of the team with Patrick and Kate. Number 3, we've heard about it before, is reducing the provincial barriers to licensure, perhaps a pan-Canadian jurisprudence process, something to allow for increased mobility, less cost, and swifter response times to disasters or anything else that requires people quickly. We have so many working nurses in this country. They are our boots on the ground experts. And as we look at supporting IENs, internationally educated nurses, and coming into various parts of Canada, I think that the current nurses are working with them every day, and they have a far better grasp, I believe, of the entry to practice needs for IENs as they begin their practice in Canada. On that note, I believe there is room, and this will come up later this morning in the breakout rooms, for pilot study for IENs to get trained in Canada while they work and get paid. British Columbia has that for healthcare aides. I know a very different animal. However, I think that our IENs require a more individualized approach to their learning needs. Some might need more English, some might need IV insertion and management, refresher courses, etc. And if we can get them here and get them working and supporting healthcare, I think we'll all be in a better position. And that's it for me. Thank you very much. And I believe it's over to Anja.
Yes, thank you, Alison. And thank you, everybody, for being here. It's such an honor to be included in this event. So I first want to just quickly bring up what is patient safety and patient care, and how do we define it? Because everybody has their own definitions. And what perspective do we define it? Is it from the regulatory body's perspective, the regulated members' perspective, the government bodies, the public, the patient, or the caregiver? So I just wanted to bring that up. Another one area that can definitely be strengthened in healthcare profession regulation is including the public and patient and caregiver voices. There is a strong need for patients on regulatory bodies. It is key to ensure diverse patient and caregiver representation, that they are included in decision-making processes to bring their lived experience into the discussion about policy, governance, and discipline. I also like that there is a focus on underrepresented communities and marginalized groups. We need to engage more with marginalized groups to understand their unique needs and challenges in accessing safe and quality care. The next area that I like to see strengthened is clear communication about complaints and disciplinary processes. Patients and caregivers often find regulatory complaint processes complex and inaccessible. There should be a clear and user-friendly communication about how to file complaints and what is expected during the process that can strengthen the trust in the regulatory body. I also feel that making these processes as transparent as possible is very important, as well as using lay language. Not everybody is versed in medical abbreviations or terminology. For many, English is a second language, so it is key to use simple to understand languages when facing the public. And lastly, a timely resolution of complaints is also very important. Lengthy investigation process can delay justice and erode public confidence. And also implementing efficient timeliness and providing regular updates to patients and caregivers can help improve accountability. And thank you very much for having me, and on to you, Lynn.
Thank you very much, Anja, and good morning, good afternoon, everyone. I'd like to build upon a lot of what Alison and Anja have shared, and that is, as a patient partner who has personally and professionally navigated through the healthcare system, I think a lot of times the understanding, the mutual understanding of the role of healthcare regulation can be a little bit unclear, and so I wonder, in terms of an area of strengthening, what could be involved is in terms of really answering or addressing the question of how does healthcare regulation not only matter to healthcare providers that are registered, but also to patients and those that care about them in the system. And this could be, through a variety of means that we'll touch upon in the next few minutes, but I think to really reflect upon this question that patient safety as one aspect is something that we all care about. So how to convey this message so that it's crystal clear for all involved. Thank you.
That's excellent. Thank you so much for your responses, and certainly some alignment with what we've been hearing today. You've touched on some of the core regulatory functions in terms of licensure, conduct, and I heard a lot about this importance of communication, using lay language, being able to better communicate to the public the role of the regulator. So excellent thoughts. The second question is more related to engagement. We know that many regulators and system partners across the system have become more focused on trying to bring diverse perspectives to their work. And I think sometimes there is this idea of including public members and treating them as sort of an umbrella term. And the engagement sometimes is not as meaningful as it could be. So I'm curious as to your perspective. How can this engagement, specifically in terms of regulators and how they work with whether it's public, patient, or caregiver partners, how can this engagement be improved in order to strengthen that relationship? And Alison, I'll go to you again first.
Oh,
And Alison, you're just muted.
Apologies. Number one, I think inclusion of public members should be mandated at the provincial or territorial level. For example, a Health Professions Act in British Columbia. I think that would be assistive. Another point is I think we really need to look at including public members from the beginning of any research or policy or committee level work, not bringing us in to give our little perspective for a moment. We should be there from the get-go. An example is education program review. I worked as a public member for BCC&M for many years doing education program review for all nurse levels in this province. And that is not across the board in healthcare in British Columbia and other healthcare regulators. So I think it's a really important piece that we all should be aware of and trying to have that start happening. I think you all have heard the phrase, do nothing to others. And this is a somewhat contentious point, but it's something that matters greatly to me, and I've worked with many regulators, is that the use of the term patient denies our personal work, life, and educational experiences. We don't give our time on this kind of endeavor today just as a patient. We're bringing all of our experience, education, work, and other initiatives to enhance the improvement of healthcare in Canada and in our own provinces at least. And using the term partners is not necessarily assistive. It's a word that gets used to help people feel we're included. However, by virtue of the interchangeable patient-public partner moniker, we are othered. We're othered from all the other people in the room who come with their acronyms behind their names. And all three of us public members today have many acronyms behind our names. But we are othered. And so we need to be more collaborative and we need to be viewed as active professionals. Assuming that the inclusion of there's an assumption that including public members means we're just to talk about inclusion of public members, like we're doing right now, exactly with this question. That is not the case. By that assumption, it leaves us out of important discussions, tables, committees, boards on what is working and not working. An example is recruitment and retention. I'm currently engaged very heavily with the Doctors of BC on recruitment and retention, and we should be doing that with nursing and all other healthcare professions in Canada. Final big point is making inclusion of public members for our diversity actually says that we, the public members, are the only ones in the room with lived experience, creating an us and them kind of dynamic. Everyone on the team should be safe enough to be open about their own diverse lived experience, whether it's themselves or family members or friends. Being mindful that by including us for diversity can segregate us from the professionals in the room. We are also professionals, doctors, architects, lawyers, teachers. We have a multitude of skills to bring to teams, and by not just bringing us in for diversity allows us to own those skills and be considered much more part of the collaborative group. Final point, it's really okay for all of you to seek public members that have the skills, experience, and education that supports the work that you need to do. I see so often, and British Columbia is quite at fault for this with their patient voice network. There's one giant cattle call of patients. We're all seen as the same, and yet we have so much diversity. We have so many different things to bring to different tables. And so it's really important that we're not just cattle called, and that you can ask for and demand from us the level of work you actually need. Inclusion often feels more performative than collaborative, and that is something just to keep in mind. Thank you very much for your time. Over to Anja. Thank you.
Thank you, Alison. I would just like to highlight what Alison just said by creating public advisory groups and citizen panels can really enhance the inclusion of public members, patients, and caregivers. Also, as I was alluding to earlier in my question in the chat, also representation on governing councils and committees is very important. And currently, as Alison was stressing, that this is not always happening, especially not across the country. Now, bringing a public perspective for reviews of policies and documentations and in the decision-making level is very crucial. And often, as Alison was saying too, patients are there for playing a certain role, and they are not allowed to step out of that role and actually be part of decision-making and policy creation. I also, from my personal experience, would like to see that there's a trauma-informed engagement for some patients and caregiver participation. Some of us have quite intense trauma that is often not considered. And then lastly, the diverse and inclusive population of the public is also very encouraged. Now, in terms of the public member engagement overall, I want to just stress that, as Alison was saying, we all have lives, we're all busy, and as advisors, we do have full-time jobs or other duties in the daytime, so in the evenings, and so it's often very important to include us in setting times for meetings and not just an afterthought that the group decided we're meeting there, can you make it? And so kind of being an outsider again and not included from the get-go, and structuring meetings so that everybody can make it. And I also would like to say that not everybody may accept or would like an honorarium for their participation, but offering an honorarium is important since many really welcome this token of appreciation for their time and expertise. And back to the communication about plain language and the usage of plain language, it's also important to create very well public awareness campaigns that raise awareness about the role of regulation and how it safeguards the public. And I feel the public awareness campaigns are not very public friendly. They are very one-sided. So including a patient and caregiver and public voice in those is very important. And lastly, providing resources in an accessible format and publishing easy to understand information on website and printed materials, including frequently asked questions, infographics, or videos explaining key topics like filing complaints or understanding patient and caregivers' rights is also very important. So I pass it on to you, Lynn.
Thank you, Anja. And I just really like to really echo a lot of what Alison and Anja have shared, that and sum up that, you know, this piece around considering what does it mean? How does it look like to engage early and often with patients and their loved ones who can be most impacted, alongside healthcare providers who are registrants, to consider that through the various means of communicating and engaging and involving or encouraging the involvement of patients, of diverse patients and their loved ones through this process. Thank you.
Fantastic insights, Alison, Anja, and Lynn. And I think what I'm really hearing is to engage meaningfully, to engage early, to ensure that public voice is really shaping all aspects of work and not just an afterthought. And so hope this provided everyone with some good insights in terms of public patient caregiver engagement. I will note that there is some, existing work that is being done that's really fantastic. This conversation is to really focus on how we can further refine that and improve our collaboration and relationship. So with that, I will turn it over to Kate, who will moderate the panel with our colleagues from DCNM, CNO, as well as CLP&A.
Great. Thank you so much, Patrick. And that was an excellent panel. Thank you so much to our panelists for your insights today. I'll be moderating our second and our final panel for today. We have 3 people who will be joining us working within nursing regulation, and our topic is around developing infrastructure to support knowledge development and mobilization. So I think Raha is going to spotlight our panel for us. We have Brent Knowles, who's the Director of Analytics and Research at the College of Nurses of Ontario. We have Sabrina Luke, Director of Research and Evaluation at the British Columbia College of Nurses and Midwives. And we have Ashley Carlson, Director of Performance Measurement and Research at the College of Licensed Practical Nurses of Alberta. So thank you so much, Brent, Sabrina, and Ashley, for joining us. I wanted to start off our conversation today by asking you about the work that your college is doing to support knowledge development and research. So maybe just a brief overview of the top, 1 or 2 highlights of your current priorities. Maybe I can start with you, Brent, and then I'll go to Ashley and Sabrina.
Great. Thanks so much, Kate, and thank you for this opportunity to share some of the work we're doing. I think most of the individuals on the panel know that CNO has sort of a long history with collecting and sharing the data that we collect related to the supply and distribution of nursing in Ontario. And this is something that we do through various reports and as well as through our website where we have an online tool to do that. But really one of the things we saw was an importance of not just sharing this, but building an understanding and the implication of the data that we're collecting. We also have a history of conducting research. But over the last year, we've actually formed a separate team, the research office, who will lead the college's initiatives to support research on behalf of the college, as well as to inform the work that's being done by other regulatory partners, as well as nationally. And this was an emerging need that we saw within our regulatory colleagues in the system for us to not just simply be doing research activities that focus on our work, to inform us, but really to inform the broader community. So when I think of some of the things that we are doing, there are a couple of really key highlights, some of which we're doing on our own, others which we've actually partnered with system partners to work with. So I think about the workforce census, which was some important work that we did last year that we're still analyzing and actually releasing results on related to the characteristics and experience of nurses in Ontario. We know that there's not a lot of work being done on that in the province of Ontario, and in fact, nationally as it relates to nursing. So we saw this as an important opportunity where we, as the college, could inform this, provide data that informs sort of both our province and also the country and what we're seeing in that area. Something that you've heard actually already mentioned is around how we as regulators evaluate the success of the regulatory activities that we are conducting. And right now we're in the process of selecting a partner to collaborate around an evaluation of RN prescribing. Ontario has just recently implemented our RN prescribing. And so this is an area with every change that we make, we look at the importance of evaluation, but this is one that we really felt it was important for us to really do a rigorous evaluation to understand the impact on the system broadly as it relates to implementing our own prescribing. And the third area that we're also doing some really interesting work around is really an analysis of the impact over the last number of years of the integration of IANs into practice in Ontario. And again, that's an example of something where we have a rich set of data across various parts of our regulatory processes that we can triangulate and look at to understand what's going on within that unique population within our workforce. But all of this is being done not just simply, as I said, to inform us, but a commitment to saying this is information we want to share with the system, to not just inform what's going on with ourselves, provincially, but also nationally. So those are a couple of examples of the things that we're working on in Ontario.
Great. Thank you so much, Brent. Ashley, would you like to chime in here too?
Great. Thanks, everyone. So at the CLPA, we've had a research function in the organization for almost about 10 years, since 2015. And as we believe that it's, as our registrant practice and profession evolves, it's really important to create new knowledge that will help inform not only our regulatory efforts, but also the safe, competent practice of LPNs in the province. And so we also see the pursuit of research at the college as an opportunity to also contribute to improvements at that systems level. And so a couple of the ways that we support research at the college is the first one is we award an annual research grant to advance knowledge about the profession, the LPN profession. Really, the ultimate aim of our research grant is to build that evidence-based knowledge on LPNs as well as on health regulation. And so this grant is an opportunity for the college to support researchers, to examine, pressing topics in our provincial health landscape, and their impact on the practice of LPNs, and ultimately the care they provide to the public. As well, it's an opportunity to examine some of those pressing issues in health regulation. And to date, we've been able to fund about 8 research projects with a number of academic institutions across Alberta, about 7 in total. And a second way, kind of a big way that we support research is we also, kind of similar to what Brent was mentioning, that they do a census, a workforce survey. We complete a large survey every about 3 years with our registrants to really get a comprehensive picture of LPNs in the province and to better understand the factors that can impact registrant practice. And so in these surveys, we've used standardized questionnaires that are often used in research. So in the past, we've used measures related to practice environment, intention to stay, burnout, resiliency, just to name a few. And so we have just actually started planning for our next large survey, which will happen next year. So we're excited to see what the results are of that. And I could go on and on about the research and support and what we're interested in, but hopefully this gives a little bit of a snapshot of how we're supporting nursing regulatory research. But for anyone interested in learning more, please reach out. Thank you.
Great. Thank you so much, Ashley. I really appreciate that. Over to you, Sabrina.
Sure. Thank you for inviting me to speak today. So the BC College of Nurses and Midwives started the research and evaluation program 2 years ago in an effort to build the college's ability to leverage its data and be able to draw insights through data analysis. And the research and evaluation team doubled in size. So we've grown quite a bit over the last 2 years. We're skilled both in qualitative and quantitative data analysis. So thinking back to what you were saying about the mixed methods being underrepresented in the research. So I thought that was really interesting as well. So the research and evaluation team, so we collect data through surveys, focus groups, interviews with our registrants, and we also work with the data collected through our CRM. Right now we're conducting evaluations to support generating knowledge in different areas. We just completed an evaluation of a 2-year pilot of a new assessment and licensure pathway for internationally educated nurses. And a component of the program is also to share out the work that the college is doing with other regulators and partners in the healthcare community. Dissemination activities include publications, conference presentations, reports. So this helps break silos. It helps us build networks and hopes that that others can draw insights from the work that we're doing, and we can do the same. We're also undergoing a broader organizational business transformation with the goal of modernizing our systems and processes. So part of this includes revisiting our data and IT infrastructure, including building a new CRM, cleaning our data, streamlining our processes to make them more efficient, and setting up an IT environment that can really allow for easier data analysis. So we've started exploring as well if and how we can use AI in our work, but we're really in the early stages of this. Another area that the college has done a lot of work on is examining how we can best address incorporating diversity, equity, and inclusion, and Indigenous specific anti-racism into our work and practices to better incorporate Indigenous ways of knowing and being. The college recently conducted a study to explore cultural safety and humility within regulatory boards and committees with the goal of developing a draft standard. And what influenced the college's decision to invest time and resources into this was really recognizing that we had limited ability to analyze data, to monitor trends, and draw insights due to the infrastructure we had in place at the college. So we needed to modernize our systems, remove silos, and integrate our data to be able to better make data-driven and evidence-based decisions and planning. So I'll turn it back to you, Kate. Thank you.
Great. Thank you all so much. It's very interesting to hear about the various initiatives that you're involved with and those that are coming up on the horizon as well. My next question is around, when you are establishing those research projects and research goals, have there been any specific challenges that you've had to overcome, or is there a facilitator that's really helped support you in developing those research goals and priorities? And maybe we could just give your top answer or top two answers. And I'll start with you, Sabrina.
Sure. So challenges to creating the infrastructure needed to support research or data analysis really includes the time and the cost needed to modernize and create an IT infrastructure that can really support easy access to data from our systems. So like I said before, we are currently undergoing this process, but it is a multi-year undertaking. And there's been a significant amount of resources and effort being put towards this, but it is taking time. We need to make sure that our data is accurate, that it's complete before we can use it for data analysis, and that we have the right tools in place to really help support this. And we also have to be mindful of our mandate and what we can and can't collect and how we can use this data that we collect. So we've had to do multiple privacy impact assessments. We've had to obtain legal consultation to see if we can collect additional data on our registrants. For example, we'd like to collect additional data on demographic characteristics as part of our DEI initiative, but it's actually proven to be a lot more challenging than we initially anticipated. We're also dependent on registrants participating and providing their data, whether through their registration or through surveys. If we get very few survey responses, it makes it really challenging to draw any sort of conclusions. We also lack the ability to make any linkages of our data to other data sets. We just don't have the setup to be able to do this. We are providing a record level data to CIHI, but we don't have a mechanism in place at the moment to provide record level data to external researchers or partners. There really is no mechanism to allow this type of sharing of data and to make data accessible to researchers. And we don't pool our data with other regulators to do any sort of research or analysis at a national level. Our data collection, as was mentioned before, it's not standardized to allow for this. We do provide data to CIHI, as I said, but as part of our national minimum data set. So I think there is momentum in wanting to establish a standardized data collection. What has facilitated us in doing this work is really recognizing that the need to be able to understand the health workforce and using the data that we're collecting to make recommendations. So I think there is momentum in wanting to do this type of work, but again, recognizing the limitations at the moment.
Yes, thank you so much. Brent, anything to add from your perspective?
Yeah, sure. Thanks, Kate. I think when I think about CNO, one of the facilitators for the support our research goals is that we're not starting at zero. I think one of the things that we can leverage is that CNO has been doing some of this work for over a decade, if not longer. So we've always sort of really put a focus on understanding the data we collect, understanding that data integrity is often a challenge that we're faced with, but really having a robust team whose focus is on sort of doing that type of analytics. Really, the other thing that facilitates us is therefore we have the resources to be able to set up a separate team and immediately spin up a team that will allows us to pull some of those research activities that we have been doing as a part of a broader analytics team into a specific team that focuses specifically on those research activities. And so that really allows us to then very quickly turn up the volume on some of those activities that we may have had to deprioritize because, you know, we didn't have a team specifically able to focus on those things. However, saying that, the challenge is always limited resources in terms of you never have enough resources to do all of the research priorities that you can identify. And so for us, really what that means is we're looking at ways that we can form those really great strategic partnerships. I believe we have a lot of great academics out there. There are really great other organizations that we can work with so that we don't have to lead all the work. We can partner, or in some ways we can support the work that other groups are doing. And really, so for us, that's one of the ways we're looking at a facilitator for this work, which is we don't need to do it all ourselves, but really we can really look at what is the work that's already happening in the system and how do we support that work that's already happening that will meet the broad-based goals, not just of us as a regulator, but as a system as a whole. So for me, those are some of the ways that we are creating that infrastructure. I think the wonderful thing is technology is always a great tool to aid this. And so tied to that is we also have a rich technology environment at CNO that we continue to leverage to support us in the work we're doing as well too. So I think those are some of the ways that we are sort of creating and leveraging the infrastructure we already have and turning up the volume on that to meet our research goals.
Great, thank you. How about from CLPNA, Ashley?
Great, thanks, Kate. I'm not sure if this first one is a challenge, but it's perhaps more of a requirement that we have to navigate. But in Alberta, there was a series of amendments to our Health Professions Act that required really the separation of regulatory activities from association type of activities. And this caused us to really carefully review the work that we do, including what research we support and can collaborate in. And so to help ensure that we're supporting research that really relates to our regulatory role, we utilize a set of criteria to evaluate those potential research projects. So we consider whether research objectives of a proposed study, research work protect the health and safety of the well-being of the public. We really keep that front of mind, you know, and does it examine such things as like looking at standards and guidance or education and continuing competence of LPNs, registration renewal requirements, or even the like influences on fitness to practice. And so, you know, I was mentioning our research grant, you know, we've tried a couple of different ways to award it, you know, including partnering with an external organization to evaluate and award the grant, you know, holding a competition ourselves where we invite researchers to submit a proposal based on their topic interests. And more recently, we're pursuing targeted research relationships based on the research areas that are of priority to the CLPNA to pursue. And that's based on a number of different factors. And so I think from this, a lesson is that there's really no one size fits all in pursuing research, but no matter what approach a college may choose to pursue, it's really important to allow flexibility to ensure that that approach will ultimately align with your organization's research goals. And I think then finally, when I think about why our research program has been successful, it's because of kind of several facilitators or factors, you know, such as we have a dedicated team to support and lead research, including myself and my research lead. We also have, you know, guiding policies to ensure we're consistent in our research pursuits and activities, and also a budget, including that annual research grant I've mentioned. And so what has helped, I think, the program, our research program, to be successful is really the networking and the collaboration we've been able to do within the academic and the research world. I think for any regulator considering establishing a research function or a program, I think building those relationships and connections with researchers is important to support your own research agenda and goals. So thank you.
Great, thank you. So I'll move on to my final question, and we have about 5 minutes left, so we'll kind of rapid fire this one. And some of you have already touched on this a little bit in terms of the time and resources that's needed to do this, and some of the ways that you collaborate or determine your priorities. But I'm wondering, you know, we know that not all regulators are resourced the same. And so maybe I'll start this question to you, Ashley, as the CLPNA being a smaller regulator than CNO and BCCNM. And I'm wondering if you have advice that you would give to other regulators about building this infrastructure or supporting research as a smaller regulator, and anything you can add around building capacity or collaboration from your experience.
Yeah, no, thank you, Kate. That's a great question. I feel like a little bit of a broken record, but one thing that, you know, came to my mind right away was, you know, by bringing people together like we are today, I think there's a lot of opportunity to build a greater awareness of what's happening in other jurisdictions as it relates to regulatory research, and to really, you know, learn from one another. I think regulators across the country are doing a lot of great work. You know, Sabrina and Brent, they, you know, noted a lot of the great work that their organizations are doing. And we probably each have ideas around an area of research that can help it answer a question for ourselves, or improve a regulatory practice, or that fill that knowledge gap. And so I think, you know, today is a really, really great start in building that capacity. And I think it's also important for connections to be made between, like I was mentioning this before, researchers and regulators, whether it's within a province or jurisdiction or across Canada. I think regulators, no matter their size, should consider reaching out to post-secondary institutions to establish those relationships with researchers, as I have found that these connections really help spark an interest in regulatory related research and can ultimately lead to a partnership. And I think what's important, you know, and Brent was kind of mentioning this too, is that regulators don't feel that they have to do research on their own, but to see research as an opportunity to, you know, build and pursue those key relationships or partnerships that allow regulators, particularly the smaller and less resource colleges, to really tap in and leverage the resources, the knowledge, and the skill set of academic researchers. And I think, Kate, this was something that you mentioned earlier on, but just to kind of wrap it up, I think it's also important that any researcher considering pursuing regulatory related research really engages regulators early on in the discussions about those research opportunities. So today's conversation has been really a great step towards that. So thank you.
Great. Thank you so much, Ashley. Anything to add, Sabrina?
Sure, thank you. I agree. I think we need to create more opportunities for us to come together and share the work that we're doing. We need additional venues to be able to present the results of research. We also need to explore how and if we can make data more accessible, especially to researchers. I think we need to have a mandate to collect information for the purposes of research, which would also help hopefully improve funding to support the costs of building the needed infrastructure. Partnering to work collaboratively on research projects can benefit all regulators, and that would be a way to mitigate the limited resources, as resources could potentially be shared between regulators to help bridge those gaps in the infrastructure. I think increasing access to grants, other sources of funding that can help support this work would be really helpful. Having opportunities like this one today to share what others are doing and challenges we're encountering is definitely helpful in building those synergies. So overall, I would say increasing the funding opportunities and having the mandate and support to pursue this type of work and collect the data needed to support the research initiatives would be helpful.
Great. Thank you so much. And Brent, last word to you.
Great, thank you. And I agree with everything Sabrina and Ashley said. I think they've covered the majority of the points I would cover. The one thing I would add to that is, I think there needs to be conversations how as we as regulators work together, because often we have shared goals. And so often I think we are each doing, you know, the exact same thing, trying to understand the same phenomenon, when we can work together and perhaps leverage the resources of one regulator to support the other. And I think about the Nurses Project that was mentioned earlier as a great example of that, a project where BC and CNO collaborated with a third organization around implementing that. But there are certain components where we were able to leverage the work we were doing and support BC and vice versa. And it doesn't need to be one organization, sort of we do that and we keep that knowledge and that we've learned to ourselves, we work together and support each other in that way. But that would mean we will have to look at how we remove some of the barriers and look at some of the legislative requirements that prevent us from doing this type of work. So I think that would be, for me, I think I would be really excited to see that happen, where we as regulators work together on some of those stuff and also leverage things going outside of regulation as well too, because things happening outside of regulation can be really important to inform how we think about some of the research we're doing. So I'll end with that, but really enjoyed the opportunity to have this conversation with my colleagues out west. So thank you, Kate.
Great. Well, thank you so much, Brent, Sabrina, Ashley, sharing your time with us today. It really adds to our other, presentations that we've had, and also our other panel as well, to give us a really good foundation for our breakout discussions that we're coming to next. So I'm going to pass over to Sophie to describe our next steps.
Thank you so much, Kate, and good morning, good afternoon to all on the call. My name is Sophie Miles. It's a privilege to be a part of this work and to share this virtual space with you all. Patrick, thank you so much for your gracious introduction earlier. So in the interest of time, I will get to the task at hand. So for the next 25 minutes, we're going to be put into several breakout rooms to discuss research ideas and barriers and facilitators to collaborative knowledge development and mobilization. We will all be asked to consider 2 research questions, so budgeting approximately 12 minutes per research question. Each room will have a facilitator and a note taker, and these insights will be used to inform the development of a research agenda as well as a research hub. Given that I have no doubt that these will be generative and really insightful discussions, we encourage you to use the chat as well, or to contact Patrick directly if there are any thoughts that you have that didn't make it into the verbal conversation. Also, this is an opportunity to highlight what you think is working out well in areas for improvement. And so I will now turn it over to Raha to send us off into our breakout rooms. And I wish everyone a really enjoyable and generative discussion. Thanks so much.
All right. As we're all coming back, hopefully you had a good discussion, and hopefully we did not cut you off, but if we did, terribly sorry, just in terms of the time that we have. But really thankful that you've provided us, for those of you who have stuck around, 2.5 hours of your time. I know you're all really busy people. Just wanted to close off quickly and identify some opportunities for you to think about in terms of future collaborations. There are quite a few opportunities in terms of grants that we can start exploring as a sort of nursing regulation system across the country, particularly opportunities through our tri-council funding agencies like CIHR and SHRC, as well as many of you will know there are some nursing specific funding opportunities through NCSBN, CNAR. We actually have Emily, who's representing CNAR here today, and she just put in a link for the research proposals that are currently open for their annual grant competition. So if that's of interest, please look into that, as well as some other opportunities that our speakers talked about. And just to close off, in the spirit of fostering collaborations, I do want to highlight that the CHWN does already have an existing database that can be used to find individuals who are working in the space of governance and regulation. So it's actually free to sign up. If you're interested, we'll put the link in the chat as well. And you can actually do an advanced search to see who's working in various areas of health workforce research. And this is a really good resource for both researchers as well as knowledge users who are looking to partner. So I think we talked a lot about, issues that need to be worked on in terms of regulation, but I also want to emphasize that there is a lot of good work happening in nursing regulation. Sometimes when we focus on the issues, we tend not to talk about the positives. And I do really just want to acknowledge that our nursing regulators are doing a fantastic job in terms of the reforms and their commitment to patient and public protection. And so with that, I know we're right on time. Thank you so much for all of your participation. I really look forward to our continued engagement. If you do have additional comments or ideas around research, please feel free to reach out. But really looking forward to continuing to engage with you in the coming months and years. So thank you so much again, and take care, everyone.